2021 in Montreal, with pre-conference activities being held on the 26th of October. Please mark that in your calendars and look at the websites of CASP, UQAM, and CRISE for further information about this major national event. I'm Julie Kathleen Campbell from the Canadian Association for Suicide Prevention. Today, I have the pleasure to introduce Dr. Simon Hatcher, full professor of psychiatry at the University of Ottawa. His main research interests include suicide, self-harm, psychotherapies, clinical trials, and e-therapies. Clinically, he works in the downtown homeless shelters in Ottawa and the liaison psychiatry service at the Ottawa General Hospital. He's the vice chair of the Department of Psychiatry. I'm also introducing Dr. Paul Links, professor with the Department of Psychiatry and Behavioural Neurosciences at McMaster University in Hamilton, Ontario. Prior to coming to Western University, Dr. Links has hold of the Arthur Summer Rothenberg Chair in Suicide Studies. I knew I would stumble on it. University of Toronto for 3 terms. This chair was the first in North America dedicated to suicide research. They will speak for about 20 minutes each about the connection between pandemics and suicides, and then we'll have a 20-minute questions. 20 minutes for questions. I get it. It's very important that if you have any questions for the presenters, that you write them in the Q&A or Q&R function, not the chat, but the Q&A, which you can find at the bottom of your screen. The presenters will not be directly reading the questions. They will spend their time concentrating on the presentation. However, I will read all the questions, and at the end of the presentation, I will select questions to ask the presenters. The total time for the whole presentation and question period will be 1 hour and will finish no later than 5 minutes after the hour. Note that all the presentations are being recorded and you will be able to have access to them and the slides from Dr. Hatcher and Dr. Links in some weeks from now on the websites of our 3 organizations, so CASP, UQAM, and the CRISE. Now, I invite the presenters to begin the webinar.
Rookie mistake. So good afternoon, everybody. Bonjour tout le monde. Kia ora. Yes, COVID has cancelled the face-to-face meetings, but of course, without COVID, you wouldn't have got this talk. So maybe there's a bright side to it after all. So what I'm going to talk about for 20 minutes is to talk about the connection between pandemics and suicides. And what this is based on is, is this systematic review article. It's called The Impact of Infectious Disease-Related Public Health Emergencies on Suicide, Suicidal Behaviour and Suicidal Thoughts, which is a systematic review which myself and Paul were involved in. It's a joint Canadian, Irish, Scottish production, a bit like the Vikings, really. And what I'm going to present is the results of the systematic review and put some flesh on the bones of the systematic review. The review is freely available, it's open access, the link is there. If you just type in crisis and Hatcher or crisis and links and systematic review into Google, it will find it. It's only been published in the last 2 or 3 weeks, but it is fully free to access. It's open access. So that's what I'm going to talk about for the next 20 minutes. This is the summary. So after doing a systematic search of 6 different databases, finding several thousand possibly relevant articles, abstracting data from them, we actually found that there are only 8 studies which provided primary data on the links between epidemics or pandemics and suicide. And these papers were published between 1992 and 2017, and they included information about Russian influenza, Russian flu, the 1890s, the Spanish flu, SARS, and Ebola. And to summarize, there is a possible impact of SARS on older adult suicide deaths in Hong Kong, but more specifically amongst older women. But there's also data from the Spanish flu and from Russian influenza, which also suggest an association with suicide deaths. So I'm going to go into those in a bit more detail. I'm going to go from the 1890s up until the present. So it's going to be an historical skip through the evidence. And this is data from these 8 primary studies which were published between those years. And I'm focusing specifically on suicide because, to be honest, that's where the most information was available. There's very little information about the links between pandemics and suicidal thoughts or self-harm or other suicidal behaviours. Most of the evidence, what little there was, is about the connection between epidemics and completed suicides. So, the Russian flu. William Osler, Canadian physician, one of the most renowned physicians of his day, he wrote this book, The Principles and Practices of Medicine, by William Osler. It was the standard medical textbook of its time. And he wrote about influenza. Serious nervous complications are marked delirium and meningitis. Peripheral neuritis was not very uncommon in the last epidemic. Mental disorders are not infrequent. Inaptitude for mental exertion, depression of spirits, even insanity may follow this. May follow an attack. The depression of spirits following this disease is one of its most unpleasant and obstinate features. Now, the book was not part of the systematic review, but I think it helps to illustrate what they knew at the time. And you know what? That's pretty much what we know at the moment in terms of brain complications. What was included in the review was a paper, basically a historical paper published in 2010, which looked at the connection between suicides and influenza in England and Wales. And they found that the suicide rate in England and Wales increased by 25% during the years of the Russian flu, so it's 1889 to 1893. And half the coroner's findings of suicide from 1890 to 1894 gave influenza as a cause. And it was in the popular domain. People would talk about flu causing depression of spirits and suicide, and there was a lot of sensational stuff in the press on this at the time. And there's a schoolboy poem from 1890 about the Russian flu. The rich, the poor, the high, the low, alike the various symptoms know, alike before it to droop. Anyway, trouble with not having a live audience, I can't say, do you know who wrote that? I can say, but I can't see the reply. That was actually written by Winston Churchill when he was 15. It tells you something about how much the Russian flu got into public discourse, public conversation. So that was Russian flu. What we found in the systematic review is that historical paper, which had some fairly compelling, low quality data, but compelling data all the same about the link between influenza and suicide rates. Coming up to the Spanish flu. Again, this is not from the systematic review, but it's really just to put some colour around the systematic review. These are screenshots from the Daily Mail of December 1918. And on the left is a small news piece about suicidal impulse after the flu. It says the foster father of Harley Moss George, aged 27, suggested at a Westminster inquest that the young man had not thrown himself in front of an electric train, but had fallen on the line through a fit of giddiness following influenza. Mr. Ingleby Oddie, the coroner, said he could not accept that theory in view of the evidence. From his experience, he knew how common the suicidal impulse is in post-influenza depression, especially in young men who feel miserable and wretched and do not like to make a fuss about illness. Suicide while of unsound mind was the verdict. So again, the link between influenza and suicide was very much in the public domain at the time. And also, there's some good remedies for influenza there. So OXO, I think maybe we should be drinking more OXO recently, and a cupful of steaming hot Evian broth clearly helps with influenza as well, not to mention the corset of health. So that's to give some colour to the Spanish flu, where it was accepted that influenza led to suicide. One of the papers in the systematic review which looked at this, which was published in the 1990s, looked at historical data from the US about the link between influenza and suicides. And what you have here are two lines. I don't know whether I can, maybe I can. This line, you see these two peaks here. That's the first Spanish flu epidemic. This is the second wave. This is in most US states, and you see that it's a wiggly line, but it's pretty much a flat line from like 1910 to 1918. A sudden peak because Spanish flu first wave, drops down again. Second peak, not as big as the first one, in early 1920. Second line is this one. It's the suicide rate in these American states. And you can see again, it's a pretty wobbly line, but it's pretty straight. During this peak here, no increase in suicides, maybe a little bit afterwards, but then a drop. It actually drops down here, coinciding with the second wave. In the paper that was published, using this data, which again is not great quality data, they did find that there's a correlation between mortality deaths, overall mortality, and suicides. But it was a pretty small correlation. See, it was a pretty small correlation. And actually, if you look here, it actually drops. And you know what was introduced in 1920 in the US? Prohibition. Prohibition seemed to correlate with a decrease in suicide deaths. And I think one of the messages from this is that what is probably more important is not necessarily so much the direct effects of the flu or the virus, but more the social and economic factors around it. So Russian flu, Spanish flu, very similar. Influenza, clearly linked to suicides in public and in the media. Some evidence from interpretation of historical data of a link between flu and suicides. But certainly for the Spanish flu, it's not that big a correlation. Biggest impact is a prohibition rather than the flu. Coming up to date, this is what else we found. There were 3 papers around SARS and its impact in Hong Kong. So SARS occurred between November 2002 to August 2003 in Hong Kong. There were 300 deaths due to SARS. If you're under 65, there's a case fatality rate of about 7%, which is quite high. But if you're over 65, over half the people died who got it. over half the people. And it also coincided with an economic shock in Hong Kong because of the quarantines and restrictions that happened at the same time. So what happened? What happened to suicide rates? So these are a retrospective analyses. There's 3 papers we found in our systematic review. First by Chan. He found that there was a significant increase in older adult female suicides, that's women over the age of 65, compared to the previous year. But there wasn't an increase in those under the age of 65. Okay, so suicide rates went up in older adults, and it was a statistically significant increase in older women. But it didn't go up to the under 65s. There's some problems to that paper. There's some missing data. Chung, larger and methodologically better paper. They confirmed that there was an increase in older adult suicide compared to previous years. And it was more common in people who had more illness, were more dependent, and worried about sickness during the SARS epidemic. And sorry. And also the third one was Yip, who looked at, Paul Yip, who examined suicide notes and other evidence in 22 older adults. And they found that the themes that were expressed in these in this data were fear of contracting SARS, fears of disconnection, and burdening others. They seem to be the 3 consistent themes in that small, not particularly random selection of suicide notes and information from relatives. This is a diagram from Chung, and I'll put it up here because it also has the Chan data in it as well. So what you see here, this solid line, is the number of suicides in older adults in Hong Kong during 2003. Sorry, that's the monthly mean in the previous years. What happened in 2003 is that is generally higher, but it's also very high during the peak of the SARS epidemic, which was in April. But then it dipped down again in June, and actually in June it actually was below average that year, which suggests that what the effect of the virus, the effect of SARS, was actually to bring forward suicides which might have occurred in summer and shift them back into spring. So there may be some effect on timing of suicides which might otherwise have happened. Now, of course, the systematic review we did was backward looking. We did it in May. We included papers up until May, which effectively excluded all but one paper on COVID. And the paper on COVID was really a preprint, a few cases. However, there is a living systematic review on the link between COVID and suicide by Anne Johns. It was last updated on the 22nd of September, so about a month ago. And according to them, there's no clear evidence of an increase in suicide, self-harm, suicidal behavior, or suicidal thoughts associated with the pandemic. This review includes all the stuff that's been published so far on the link between COVID and suicide. And again, that's open access, anybody can access it. Why may there be a connection? Well, of course, there's the social issues around unemployment, anxiety, making depression worse. But of course, it's not to forget that the virus has a direct effect on the brain. And this is something that William Osler recognized, and he spoke about sort of odd neurology, which occurs after the Russian flu. It happened after the Spanish flu, and looks to be happening after the coronavirus as well. Just look at the COVID long haulers, for instance. So brain involvement is common in COVID infections. You get loss of smell in about 30% of people. We know the virus replicates in the brain. And as I've said, in past epidemics, post-infection depression was common and widely recognized. There was a range of psychiatric presentations from anxiety to psychoses. There's odd neurology, the whole Oliver Sacks' awakening story. Encephalitis lethargica was a post-Spanish flu phenomena. But interestingly, the brain complications don't seem to be related to the severity of the respiratory illness. So there's lots of reasons, both directly and indirectly, why the virus may be associated with an increase in suicides, although the evidence is not particularly compelling. So to conclude my part of the talk, the main lessons from the Russian and Spanish flus are that depression and suicide were widely recognized at the time as a consequence of the infection. The evidence of SARS in Hong Kong is of an increase in older adult suicides, particularly in women. And there's not much evidence so far about the links between pandemics and suicide, and what there is not great quality. So that ends my part of this talk. So I've got to get out of this somehow.
Je pense, I'm guessing that Paul is trying to get his PowerPoint online. You're muted too, Paul.
Yeah, I'm just trying to, haven't seen it yet for some reason. Let me try it again. It's not showing my desktop for some reason.
It's so nice when we try it just before and everything works fine. There we go. So you now have your screen. We just need your presentation.
Good. I think I'm ready to go then. So
what we see right now is your Zoom link. It's not the your PowerPoint.
Oh.
Maybe you want to reshare your screen?
Hi, Mr. Link, Luc Dargy here. I would suggest to stop the screen sharing and choose the PowerPoint option in the screen sharing windows.
So if you just want to stop sharing for now, stop your sharing your screen. Yeah, and then click back on share your screen, but choose the PowerPoint.
Yeah, I don't see it for some reason.
It ran away. Has it been minimized?
Is your PowerPoint open on your computer?
Yes.
Oh.
So we apologize for the little technical issues. Working with technology is always a bit unpredictable, and there we are.
That done it? Is that showing it?
Yep, that works.
Oh,
You're
yeah.
good.
For the glitch there. So I'm going to work from the information provided by our systematic review that there was a suggestion for an association between infectious disease, public health emergencies, and suicide. And I'm going to talk more about what would be the implications for primary care in particular, but I think this will be very relevant for any of us doing mental health outpatient care. Again, this is work that our knowledge synthesis team has pulled together, and some of our ideas of the implications of this work. just to say I have no conflict of interest. So what I hope to do is talk about what we think some of the implications of this work is for primary care and other mental health clinicians trying to prevent suicide during a pandemic. I'll also talk a little bit about the issue of doing virtual suicide risk assessment and management, and also the potential use of smartphone tools as part of virtual care. So I think we've all recognized that our work with mental health patients can prevent suicide, but we also know that the patients that we see do go on to suicide, and this is well known that 75% of those who died by suicide had seen a primary clinician in the year before, and 33% would have seen a mental health clinician in the year prior. And this is actually data that we did a confidential survey in Southwestern Ontario, and it just confirmed the same thing. And it showed that 63.5% of people who went on to die by suicide had seen their family doctor within 28 days of their death. And 40% of them had seen the family doctor within a week of the death. So it does indicate that we have an important role in suicide prevention. In this group, men were less likely to have been seen prior to the suicide, although it wasn't a significant difference in the sample. And we inquired with the primary care clinicians whether they had done an assessment, and 87% of them indicated they had done an assessment. They were aware of the person's risk, but of course they went on to die by suicide. And men were less likely to have been assessed in the 3 months prior to their death based on our confidential survey. So I think we've long held that primary care providers and those of us doing mental health outpatient work are really central to suicide prevention. And we believe the pandemic really creates some new considerations in terms of our work to prevent suicide. Now, the systematic review, as Simon indicated, talked about a number of pathways, but two that were particularly supported was that people were affected by the dread or the anxiety, particularly reflected in media reports. And that seemed to be part of the mechanism leading to increased risk. And of course, the response to the pandemic with isolation, loneliness, and disconnectedness also seemed to be an important factor, particularly noted in the SARS Hong Kong data. But it does seem, certainly one of the theories is that the pandemic acts as an acute stress on people with pre-existing vulnerabilities, and that I think we would expect. And we also feel that there's some evidence that some people will be at reduced risk during these episodes, maybe because the family ties are reestablished and it might be act as a protective factor. But given that we have evidence of who may be vulnerable in this circumstance, I think particularly we want to focus on older adults who are totally or partially dependent, and certainly those who have pre-existing anxiety, particularly health anxiety, as groups to recognize that they may be particularly affected by the pandemic. And I think this leads to two rather simple but important strategies that as a care provider, we should really try to have people limit their access to media reporting because it can be very negative and anxiety provoking, and also to work hard to maintain the social support for the elderly, whether it's virtually or whatever means is possible given the restrictions. This seems to be an important part of preventing the risk. Now, a pandemic situation leads to the need for doing virtual suicide risk assessment and management. And there is some guidance around this, I think, through my look at the literature. Jobs has published about using collaborative assessment and management of suicidality through telepsychiatry. This, of course, is a particular way of managing risk that looks at sort of the positive and negatives the person's experiencing and trying to build on the positive aspects. and they've had years of experience with this as a telepsychiatry format. Then Barbara Stanley has published some managing suicidal clients during COVID. It's a very useful document that provides some good management tips. Two that I think that are really important to keep at hand is that, anticipating that you may find a patient to be at very high risk, it's important to gain information about the patient's exact location at the start of your virtual session, so that if you need to intervene as a crisis, you know the patient's location. And also to ensure that you have alternate methods of connecting with the patient if your video line goes down or is bad. Now, there is some evidence for virtual mental health care, and we did look at some of this evidence, and it tends to be in a general format that generally telemental health is comparable to face-to-face treatment if you're talking broadly about mental health. As I say, there's some years of experience using collaborative assessment and management of suicidality, but we really feel that there's less known about the specifics of how we should do suicide assessment and management virtually. And actually, our group has proposed to seek funding to develop a guideline that might help us be more specific about what are the best approaches to suicide risk assessment and management using virtual or telephone methodology. Now, working virtually, it's generally been suggested that we use screening and assessment tools. When we talk generally, the Joint Commission, which is like Accreditation Canada in the United States, has actually called for screening in all healthcare settings, but there's a lot of debate about that. The National Action Alliance for Suicide Prevention in the US talks about selective screening. For example, if you're working in primary care, to screen all patients with mental illness or substance abuse, or in emergency departments to screen all patients who present with suicide risk or those with mental illness or substance abuse. But given that screening and assessment is moving towards more tools, like the PHQ-9, which is often used in primary care, and even though it's a very brief tool, this data just indicates that even using the 9th question on the PHQ-9, it still has a good predictive value. As you can see, prospectively over 90 days, it can predict suicide attempt or the prediction of suicide deaths. The other widely used screening tool is the Columbia Suicide Severity Scale. And again, this tool has been used in various settings, and it has been adopted in primary care settings. It can be used as both a screening and assessment tool, and it does have some reliability, although its validity is still to be established. I think one reason why it is widely used is it's freely available, and the training is also freely available. And I just list here some other, obviously there's many other measures, and the measure will depend on your setting and population, but these are some sites where you can get further information about reliable and valid measures. But understanding that we're using more screening and assessment tools, we have to think about how to use them in the virtual environment. And the National Action Alliance for Suicide Prevention has provided some guidance around this that I'll just highlight. If we are using suicide screening tools, and they recommend that for people who are being followed for mental health disorders, it's very useful to send these out before a scheduled visit as part of your routine care. And if this is done, it'll be important to identify the protocol for which you monitor these screenings. For example, you have to designate a particular person to review the screenings, and then the steps that are taken if the person has a positive screen. And again, this paper from the National Action Alliance gives you sort of a methodology to set up a protocol. An important part is if you're using asynchronous screening and assessment tools, on the tool it goes to the patient to indicate that the screenings will be reviewed and also to inform them about what crisis help there may be available. Because often it's not possible to immediately respond to the positive screening, and the person will need to know the crisis resources. The other area that I think is important as we move to the virtual assessment of suicide risk and management of suicide risk is the possibility of using apps to support our interventions. I mean, they have a lot of potential because they can be used in situ and they can be used when the patient's in crisis. So Larson and colleagues tried to do a review of apps that might provide resources for suicide assessment and management. And overall, both from their paper and a bit of from our own work, there seems to be an absence of efficacy data about smartphone tools for this purpose. I think there is some promising findings, but it's still very early in knowing the role of these tools for management. So as a result, Larson and colleagues did a content quality review of apps that were available. This is actually an Australian study, but they looked at the quality of these apps for suicide prevention purposes. And their criteria, they reviewed the app's characteristics. Did it focus on suicide prevention? Did the app have harmful content that had to be avoided? The actual app quality? And then did they actually include suicide prevention tools? They judged these against the World Health Organization report on suicide, some of the established reviews on suicide prevention, and also those practices that were consistent with best practice. In their review, they actually found 1,200 plus apps that they could consider, and they selected out 49. But I think the results of this are quite informative. Of these apps, the main emphasis was on safety planning and providing access to local crisis services. So those are the two main kinds of interventions that existed on apps. Some of them did contain harmful material. For example, they found that some apps were suggesting the person should use drugs or self-harm to manage the crisis. Overall, the apps did not provide multifaceted suicide prevention strategies. As they say, they focused on the safety planning and crisis resources, but there wasn't much on risk factors, triggers, or actual psychological interventions that the person could access. There was also difficulties with privacy and privacy policies. The apps had difficulties with protecting the information and locking. Now, as I say, this was done in an Australian context, and I think, again, our group is seeking funding to try to do this in a Canadian context to know what apps available in Canada can provide support for virtual assessment. So in conclusion, just to indicate if it is correct that the pandemic will have an impact on suicide, there's many other questions I think that remain to be explored. As Simon said, we really don't know the significant pathways between the pandemic and suicide. Certainly some of it may come from the infection itself, some of it may come from the public health response, and obviously some of it comes from existing risk factors that are worsened with the crisis. As I say, there's many opportunities now to be doing work virtually, and we need to know how best to do this in terms of assessing suicide risk and managing suicide risk. And finally, although I've mentioned a couple of possible prevention approaches, we have yet much to learn on what to do in a pandemic to avoid an increased risk of suicide. And I'll stop there.
Thank you, Paul. Thank you, Simon. Just a reminder that yes, we will have access to the PowerPoints. The presentation is actually recorded, so you will have access to the webinar itself, but also to the slides from Dr. Links and Dr. Hatcher. So feel free to write questions in the Q&R, and I'll be pleased to forward them to our presenters. I would start with a questions to Dr. Links. There's already a lot of discussions around suicide risk assessment in the first place, even in person. So what are your suspicions where virtual suicide risk assessment should be modifying or adapting to adapt to the reality of being online, but also to adapt to different type of clients? Like, is it different from men and women, or is it different for older and young youth?
Yeah, I mean, I think it's an important question, and as far as I think our group knows, we don't know the answer to that. But so in some of our discussion and with colleagues, there is some feeling that maybe with young people, it is more difficult. I mean, that can be true in person, but it may be more difficult to solicit the sort of information you need. Obviously, the uncommunicated patient, and I found patients who tend to deny or downplay their symptoms, you really miss having that face-to-face contact. And then the final group is where there's a concern for psychotic symptoms. I think that's been another area where people feel like the virtual format can be challenging. So these are just suspicions. I think we do need to do the research to try to understand, you know, what modifications we need in the virtual environment.
Thank you. Dr. Hatcher, you presented very different views on pandemic having an impact or not having an impact. Do people think that suicide rates, my apologies, will change in Canada because of the pandemic? And if so, what could cause that difference from, example, the Spanish flu in the 20s?
I really don't know. The modelling we have from elsewhere suggests there's going to be something like a 25% increase in suicides. But one of the things we've learned from COVID is that modelling isn't actually that good. But 2 points. First, if mental health is going to have the same parity of esteem as physical health, we should be putting the same effort into modelling mental health outcomes as we do in physical health outcomes. So we should be aiming to flatten the mental health curve as well as the consequences of the COVID infection as well. We really should be putting investment and time into doing that. And I know that some agencies, FAC, for instance, are doing this. But I think it's just an important principle that if mental health is going to have the same parity of esteem as physical health, then we should be doing the same sort of modelling they do in for COVID itself. The second thing I wanted to bring up was about fear and dread, because you know that's one of the things that in Hong Kong they found associated with suicide in older people. I was quite interested in that. And I was interested partly because in the way the Spanish flu was managed, which is very different to how we're managing it. In that it began in wartime, where the government very explicitly managed people's fear and dread of being in war. And to begin with, they ignored the Spanish flu. But then it became hard to ignore. And then they used some of the same sort of mass communication techniques to manage people's fear and anxiety about the Spanish flu. And one of the things I worry about in Canada is there doesn't seem to be much psychological input into public health messaging. I don't think we manage fear and dread well enough in our responses so far. And I think at a population level, the message we get is that this stuff is to be feared, but it's nothing more than that. I think we could be doing a lot more at a population level to manage people's fear and dread, which intriguingly looks like it might be connected to the risk of suicide. And I think, again, we can learn from history about how we might be able to do this differently.
Thank you. Pandemic and suicide in healthcare workers. Can you give us your thoughts on the needs to develop specialized PTSD services and trajectories specifically towards healthcare workers? Either of you.
I can begin to talk about this. I'm a frontline health worker, and I've also provided some support for one of the organisations I work with. And I think I'd say two things. One, if you focus on PTSD, you'll miss most of the mental health injuries. It's not all PTSD. It's depression, it's anxiety. PTSD as such is relatively rare. The key thing to keep in mind when managing healthcare workers' responses to the pandemic is Maslow's hierarchy of needs. The first thing people want is not referral to therapists to do individual one-on-one therapy. What they want is to know they can take a break, have somewhere to eat and somewhere to drink. That's the first thing. Second thing is they need safe places in which to talk and share feelings, and they need to manage and improve bonds between team members. And again, there's good evidence of most of that stuff. And then the next thing you do going up the hierarchy is then you might want to start identifying individuals who may need extra care. So the way that this has worked out in one of the services I work with is that there's a very good management who have clear, consistent messaging, who essentially create the sense that the organization has got your back. And that's what this is all about. And beyond that, we created spaces where people could come and talk and just discuss how they're feeling, discuss cases, discuss difficult situations they found themselves in. And a few people, and they were usually generally people with past psychiatric problems, needed a bit more than that. I ended up seeing them in a clinic at the Ottawa hospital. So I think there's good evidence-based responses. And of course, the other thing to bear in mind is that where we are now psychologically is different to when we started back in March and April. It's very different psychological territory. The psychology of responding to pandemics changes over time.
Paul, you want to add to that?
No, that was a great answer. I don't really have it.
Okay, thank you.
It's lived experience.
Can you give an example on how to manage feeling of fear and dread at the population level?
Nope. Well, that's not entirely true. It's difficult, and I haven't thought this through properly yet, but how it would actually work in a 21st century economy. In the beginning, 100 years ago, when the press was much more centralized and amenable in wartime to government diktat, it was much easier. You actually had press barons who were part of the wartime cabinet, and there was almost like a direct line of communication from government to the media, to the public. And so one of the ways in which the people managed dread to begin with the Spanish flu is they ignored it. And if you look in the Daily Mail from December, it's the only time I read the Daily Mail actually, it's 100 years old. You look in the Daily Mail from 1918, you will see it does mention the Spanish flu, but it's like right down the bottom of page 3 in very small type. And it's something like, oh, 150 people died of the Spanish flu in this London borough last week. It's like, it's almost quite completely ignored. And it's only later do different messages start coming out in the press. I mean, I think it's a really interesting, I think it's an interesting idea. And I think it's something that's interesting to research. And I think it would be maybe having people more expert than me looking at this at a population level in Canada and trying to inform some of the management at a population level about the management of fear and anxiety.
Thank you. Dr. Links, 2 questions for you. Are you able to speak as to why there may be a debate about screening all patients for suicidality in primary health care? And another question I will throw at you right away because it's a little bit in the same way. What do you think about a national 3-digit number for people that are in crisis?
I'll take the second part first. I would be in favor of that. I think that's a great way to increase access to crisis lines. And hopefully we're moving in that direction. I think the debate about whether we should be screening, say, everybody in certain settings like primary care is a useful debate, but I think it arrives from the fact that we don't have adequate screening tools. The tools that we have, really have a lot of difficulty. They probably screen many people who are positive or not going to go on to suicide. And so none of them really have adequate psychometric properties. And certainly they might be proven in a particular setting, but they probably don't generalize to other settings. However, I think the value in many of the screening and assessment tools is they do ensure that you cover the content that you might need to do, given what we have to work with clinically. And I think another important aspect is it can really make the language in which we talk about people at risk uniform, because that can often be a problem. Somebody might call a certain behavior a manipulative suicide, and another person might call it an aborted suicide attempt, and those can carry very different meanings, I think, if the communication isn't specified. So I think the debate's a healthy one, but I think screening and assessment tools have their place.
Thank you.
And of course, the other why people don't screen people is that they don't know what to do with the answer. I mean, if people say yes, well, what do you do? Well, you spend the rest of your clinic trying to find a mental health practitioner who'll talk to you, and or maybe get the person to hospital, because most mental health services are stuck behind hospital walls. So that's another issue. Sorry to interrupt. I'll shut up.
Actually, that's your job to answer, guys. I'm just here to ask questions. We've talked about in the presentation about there was more suicide with the older people. One person is asking whether there's any research on determinant for adolescents suicide during pandemic.
Yeah, so this is our correspondent from Kazakhstan, which I'm impressed by. Yeah, I don't know how many other people from Kazakhstan are on the line, but there you go. The answer is, of course, it's like everything in child and adolescent psychiatry. If there's little research in adult psychiatry, there's usually nothing in child and adolescent psychiatry. So there's not a lot of evidence, nothing that we found in our systematic review, which addressed younger people. Certainly the data from Hong Kong and SARS suggests that the suicide rate didn't increase in younger people compared to the older adults. Yeah, absolutely right. It's one of the hard topics to research, partly because the numbers of completed suicides are thankfully relatively small in adolescents, certainly in Canada. Not to downturn them, but not to dismiss them, but the numbers are relatively small.
The other comment I would make is that there might be other demographic groups that are at risk. If I recall correctly, I think Simon touched on this, in the Russian flu, there was some suggestion that young men in particular might be affected. And if you look at other kind of crisis events like hurricanes or other natural disasters, there's some of evidence in those situations, perhaps young men or younger men would be particularly at risk, perhaps related to the economic consequence of, say, a natural disaster. So the point being is, I think there's still lots to learn about the impacts of something like a pandemic, and it may be very specific to the particular area and culture, etc.
Thank you. Clarification question. Just to make sure I understood, there is no measurable increase in suicide over the last 6 months, is there?
Who knows? The difficulty with suicides is that, certainly in Canada, suicides are defined and determined by a coroner. And to do that, they have to go through a coronial process, which is time consuming. And because of that, accurate figures, or up-to-date accurate figures about suicides always lag about at least a year, sometimes 2 years behind, because some inquests take a particularly long time to do. The other thing to say, so that's suicide. Self-harm, intentional self-harm, people coming into hospital after taking an overdose or cutting themselves or whatever. Again, we don't really know. Where in the hospital I work in, the week after the pandemic emergency was declared, in the middle of March, the numbers of people presenting to hospital with intentional self-harm just halved. It just dropped like a stone. But of course, that's because nobody's going out. Nobody's going to hospitals. The last place you want to go to in the middle of a pandemic is a hospital, because it's full of sick people with flu. So you don't want to go there. So people are tending to avoid hospitals. So again, we don't really know what's happening around self-harm. The evidence around John's living systematic review is that it doesn't seem to have big impact so far. I suspect it's going to be one of these things which is going to happen not immediately, but take its toll over time.
Thank you. We are 2 minutes before the end. So before I officially thank you and conclude this session, would you have any last famous words that you would like to share with our participants?
No, just thanks for the opportunity, and we have to keep our study of this relationship going.
I'm going to channel Jacinda Ardern, the New Zealand Prime Minister, and I think the main message is be kind and be kind to each other. And the second thing is, and this is kind of one of the questions, I think, is that the COVID pandemic, I think it highlights both the problems and the advantages of thinking about suicide as a mental health problem. On the one hand, as I mentioned in my talk, the virus clearly affects the brain, but on the other hand, it's the social stuff which seems to have the biggest impact on suicide rates. So I think it gives fuel to both sides around the idea that treating suicide as a mental disorder, as a result of mental disorder, is the way to go. I think it both supports and challenges that idea, I think.
Thank you. So we had a lot of questions. Unfortunately, we couldn't go over all of them, but we also received a lot of thank you very much. That was very informative and a rich session. So I want to pass this on to you guys. To all our participants, I remind that the session was recorded and will become accessible with the slides from our two presenters in a few weeks on the website of the three organizations, CAS, the CRISE, and UQAM. There's still webinars to come tomorrow and Friday. Registrations are still open. You're welcome to have a look and sign up for those. And reminding you that next year in October 2021, we are hoping to be able to meet in person, but our next national conference would be in Montreal. So keep an eye. We're probably going to open the calls for communication very soon. Thank you to Paul. Thank you to Simon for your time and your expertise. It's been very appreciated. And thank you everybody for joining for this webinar.
Thank you.